Hello everyone. Today we will discuss about one of the trending topic in CKD management, that is nothing but discussion about non-steroidal MRAs, in particular Finerenone. So how this newer molecule is helping in cardiorenal protection we will discuss. So for this I want to give you some of the basic details when it comes to CKD, in particular due to diabetes mellitus, which we say it as DKD. So we know that in diabetic kidney disease, the mineralocorticoid receptors, which are there in three major sites. First one in the cardia, second one is in the renal system, third one is in the vascular system. So these will be normally there in every individual, and over that aldosterone will be coming and doing some action, as well as the hormones such as cortisol and reactive oxygen species, which will be increased during the time of stress. So all these factors will come and act on these receptors, and they will have numerous effects. But in DKD patients, these will be in overaction. So they will be overactive, leading to the adverse effects in diabetic kidney disease patients. So what are those adverse effects? I hope you all know, when it comes to cardia, it will lead to fibrosis, apoptosis, inflammation, hypertrophy. Overall, cardiac remodeling will be happening because of this. When it comes to vascular, these will lead to endothelial dysfunction, which is the major driver for adverse cardiovascular events. When it comes to renal system, there will be proteinuria, renal vasoconstriction, glomerular injury. With all these, we can say there will be increased action of the RAS and sympathetic nervous system, which over a long term is not a good change, we can say. So these are all happening in DKD patients, putting them at high risk of cardiovascular adverse events as well as the faster progression of chronic kidney disease. Now we will see how our molecule of today's discussion, that is Finerenone, is helping in dealing all these adverse effects. So what Finerenone will do is, it will come and block the mineralocorticoid receptors, which we can say the similar action as steroidal aldosterone antagonists. But the major difference is, this molecule is considered as a bulky antagonist. So what does it mean? When it comes and sit over the receptor, there will be no space left for the other molecules to come and exert their effects, especially for the cortisol and reactive oxygen species. So these will not be able to come and sit on the receptor, so their effect will be lost. With this antagonism, there will be no stimulation of the nucleus, halting the process of fibrosis, hypertrophy, oxidative stress, inflammation. With this, it will help in improvement of vascular health as well as kidney and heart health. So this is the mechanism of action of Finerenone, we can say. When it comes to its pharmacokinetics, it has some special mechanisms. As I mentioned, it is non-steroidal MRA. So there will be no sexual side effects when we compare it with the steroidal MRAs. And it has very high affinity for mineralocorticoid receptors and high selectivity when it comes to the comparison with steroidal MRAs. And regarding the distribution between heart and kidney, this molecule has equal distribution of 1:1, whereas the previous classical steroidal MRAs like spironolactone used to have 1:6. So they used to pool more in the kidneys, whereas their effects will not be much beneficial when it comes to cardiac health. So this distribution is again an advantage when it comes to this molecule. And the bioavailability is 50% nearly, and the half-life is 2 to 3 hours, and there will not be any dietary impact on the timing of this pill. So overall, from this slide we can say there will be higher affinity and selectivity on mineralocorticoid receptors, and it will get distributed equally, so that we will get the benefits in cardiac cases as well as chronic kidney disease individuals. So now we will discuss the comparison of steroidal and the newer non-steroidal MRAs. As I mentioned, the affinity and selectivity towards receptors will be higher. So this is one advantage. Tissue distribution, just now I mentioned, this will be 1:6, whereas this will be equal 1:1 ratio. And because of non-steroidal nature, there will be lesser sexual side effects. If you remember, spironolactone had tender gynecomastia as the adverse effect, as well as some of the other sexual side effects, we can say. And when it comes to hemodynamic impact, we used to observe significant hypotension risk with steroidal MRAs, which is lesser with this newer molecule. Similarly, from the studies, they have claimed that hyperkalemia risk will be lesser with this newer molecule, but the point here to remember is clinical trials will be an ideal situation, but clinical practice will be totally a different real scenarios where it will be very difficult to monitor potassium and all. So consider the hyperkalemia risk as higher only even when it comes to Finerenone. Now we will see some of the trials evidences when it comes to non-steroidal MRAs. So the phase 2 trial named ARTS and ARTS-HF have shown that there will be significant reduction in BNP as well as albumin-urea, benefiting heart as well as kidney health. And in particular, ARTS-HF trial has shown that there will be decreased hospitalization due to heart failure and lesser emergency presentations, as well as there will be lesser overall mortality when they use this particular molecule. Few of the other landmark trials to mention on this molecule are ARTS-DN, that is diabetic nephropathy, Fidelio DKD and Figaro DKD trial. Overall outcome, if we see, there will be dose-dependent reduction in urine albumin creatinine ratio at 90 days and definitive decline in albuminuria, overall prevention of the progression of kidney disease, and there will be reduction in deaths due to any cause when it comes to chronic kidney disease. Similarly, the cardiovascular outcomes are significant reduction in overall cardiovascular outcomes and lower incidence of fatal cardiovascular events. And the mechanisms, probably you might have understood by now, there will be decreased myocardial and renal fibrosis, there will be suppressed systemic inflammation and improved structural hemodynamics with this molecule. And one more important clinical trial to mention is confidence trial, where they have combined SGLT2 inhibitor empagliflozin with nsMRA Finerenone, and it has been observed that there will be synergistic reduction in urine albumin creatinine ratio without further deterioration of renal function. Also, surprisingly, they have observed that by combining these two, whatever the expected hyperkalemia was there with Finerenone, it will further come down, and the overall adverse event rate will be lesser when we combine these two. And this was done in DKD patients. This point we have to remember, diabetes plus chronic kidney disease. So how to deploy this in our clinical practice is, especially in CKD, if the patient is already on maximum tolerated dose of RAS inhibitors, that is ACE inhibitor or ARBs, but there is insufficient control of the kidney disease in terms of proteinuria. So in that case, we should add on with nsMRA Finerenone. And this point is supported by various international consensus like European Society of Cardiology, ADA and KDIGO. So the guidelines are very clear for the usage in favor of this molecule, but definitely it will take years to come into the practice. But knowing with the current guidelines and being updated is very important. We will see the dosing protocol of this molecule. So initiate with the low dose, that is 5 mg daily, and we need to check potassium every 4 weeks without fail, because there will be high risk of hyperkalemia. And if the patients are tolerating this molecule and potassium are under control, then we can gradually increase the dose to reach an optimal maintenance dose of 20 mg daily. But the point here to remember is, do not use or do not initiate this molecule if the GFR is less than 25 and if the potassium is more than 5. So these two numbers we have to remember. When it comes to special population, in particular geriatric patients, there is no need to alter the standard dosage, because it has been observed that age does not impact the pharmacokinetic of this molecule. But if there is hepatic impairment, especially class C of child pug, you need to avoid this molecule, and if there is class A or class B child pug severity, we need to be more cautious and we need to monitor the individual vigilantly. Thank you so much. This topic we have discussed because it is in the trend and presented at various CMEs or scientific sessions. So I want all my viewers to be updated with the current trends in medicine, so that we can directly enjoy the CMEs which are meant to be for update, as well as food and drinks, we can say. Thank you so much for watching this video. Also, do not forget to share these updates with your colleagues. And if you find our videos are helpful, do not forget to subscribe and support our channel. Thank you so much. See you in another video. Till then, take care.